Great. Thanks, everyone, for attending our PHSSR Research in Progress series. Today, our topic is trends and characteristics of the state and local public health workforce. I am Rick Ingram. I'm an assistant professor at the University of Kentucky College of Public Health. I also work for the National Coordinating Center for Public Health Systems and Services Research and Public Health PBRNs. Our presenter today is Angela Beck, who's an associate director of the Center of Excellence in Public Health Workforce Studies at the University of Michigan School of Public Health. Angela is also a research assistant professor in the Department of Health Management and Policy and associate director, as I said, of the Center of Excellence at the University of Michigan School of Public Health. She began her career working on public health workforce development initiatives. She has served in a fellowship at the Health Resources and Services Administration, where she assisted with management of the Public Health Training Center programs. She's now engaged in public health systems and services research with a specific interest in the public health workforce enumeration, as well as measures of organizational performance and effectiveness of public health departments. She has a bachelor's degree in physiology from Michigan State University and an MPH and PhD from the University of Michigan School of Public Health in Health Behavior and Health Education. And after her presentation, we'll have some commentary from Rivka Liss-Levinson, PhD. Rivka is the Director of Survey Research at ASTO, the Association of State and Territorial Health Officials. Her primary responsibility is the design and implementation of the ASTO Profile Survey. She also develops and implements the Budget Cuts Survey Series and the Forces of Change Survey that ASTO fields.
One of you print this out.
And she also collaborates on the Public Health Workforce Interest and Needs Survey, which is the Public Health Wins Survey. She provides
You're like, no?
technical assistance and consultation on surveys consulted by ASTO staff in response to internal and external data requests. So having said that, let's start. One quick note, Angela is one of our 2013-2014 pre- and postdoctoral research awards recipients. This is a list of the mentored scientists awards who've presented to date, and they are available at the web address above, www.publichealthsystems.org/phssr-research-progress-webinars. So they're all available there for your consumption. And again, our presenter is Angela Beck. Angela, would you like to start?
Yes, absolutely. All right. Thank you so much, Rick, and thank you to the participants who have joined us on this webinar today. As Rick mentioned, I work at the University of Michigan Center of Excellence in Public Health Workforce Studies. Our center was established in 2009. We're primarily funded by CDC, although we have had some supplemental funding from other sponsors such as RWJ, HRSA, and the Kresge Foundation to do some more specific special projects on segments of the public health workforce. Overall, our center is interested in studies that assess and characterize public health workforce size, composition, and capacity to deliver services. And if you're interested in seeing findings of our studies, you can download them. They're all available at phworkforce.org. This particular study that we're discussing today was funded by the PHSSR National Coordinating Center, so thank you to them. Also thanks to Matthew Bolton, who is our center director and served as the faculty mentor for this project, Rivka Liss-Levinson from ASTO, who you'll hear from shortly, and Carolyn Leap from NACCHO. Also need to mention that an article detailing the study is currently in press at the American Journal of Public Health. So that means I'm a bit limited on what I can present in terms of tables and so on, but I can provide a summary overview of our findings. So when we think about the public health workforce, we know that a highly trained, competent workforce is essential for effective public health service delivery. Despite the workforce being such a key, essential piece of the public health infrastructure, pretty modest investments have been made on a national level at this point to try to systematically monitor workforce characteristics such as size, composition, demographics, the training and education background of our workers, and so on. There's been increased interest in the public health workforce recently due to the budget cuts that have been sustained by health departments, for example, healthcare reform mandates, which may impact what our workforce looks like and what it does, and impending retirements. We know that some retirements have started. We're expecting more in the coming years. So at this point, there really is no national system for monitoring the public health workforce. So when we try to conduct studies like this one or basic enumeration studies just to get a sense of the size of our workforce, we typically have to derive enumeration estimates from multiple data sources. So that could include data from professional associations such as ASTO and NACHO profile surveys, studies conducted by universities such as our Center of Excellence and others, practice-based research networks, and maybe these folks aren't doing national studies of the entire workforce, but often there are smaller studies being done on certain segments of the workforce that can help inform a national enumeration. And then there are also national data sets, such as data released by the Office of Personnel Management on federal workers. The Bureau of Labor Statistics, of course, collects employment data on all civilian workers, but their data is really not specific enough to provide us with a good picture of the public health workforce. We just don't get enough detail from those data sets to kind of present an accurate picture. So what we end up doing is kind of taking these different types of studies and trying to piece them together to create a picture of what our national public health workforce looks like, particularly at the government level, because that's where most data are available. The most recent national enumeration of the governmental public health workforce was actually released this year. It's currently available this month in the November supplement issue to the American Journal of Preventive Medicine. So if you're interested, this is an open access article. It's available on our center website and on the AJPM website as well. But a couple things that I just wanted to point out quickly that help inform the study we're talking about today. You can see that we used 14 occupational categories that are often used by ASTO and NACHO, regularly used by ASTO and NACHO in their profile surveys. You can see administrative and clerical personnel kind of make up the biggest group of the public health workers that were able to be categorized in this study. The biggest group of workers that are more involved in providing public health services would be public health nurses, and they came in at around 16%. You can see that there's a row near the bottom that says other public health professional or uncategorized worker, and that represented about 30% of public health workers in this study. And what that means is either there are workers who are employed in an occupation that is not captured by one of these 14 categories, or the respondent, the health department or agency respondent, had difficulty categorizing their workers. Either that information wasn't readily available to them, or they had difficulty kind of assigning workers into a category. So I think this further speaks to the need for a more systematic method for data collection that will be kind of easier for agencies to utilize and provide us with more regular, systematic estimates of the public health workforce. Just another note here, about 50% of the governmental public health workforce is at the local level, 30% at the state, and 20% at the federal. We'll be looking a little more closely at local and state in this particular study. So the purpose of the study we're talking about today is to assess occupational characteristics of the state and local public health workforce from the time period of 2010 to 2013. We were also interested in whether we'd find any differences in workforce occupation in terms of the number of people that make up those occupations when we looked at different types of characteristics of health departments. So we looked at size of population served, we looked at geographic region, and we looked at the governance structure of the health department. We're also interested in seeing whether the workforce profile changed over time. So when I say profile, I'm meaning the occupational composition of the public health workforce. So the number of epidemiologists or the proportion of the public health workforce that's made up by public health nurses. For our data sources, we used ASTO and NACHO profile survey data. For ASTO, we used the 2010 and 2012 data sets. NACHO, we used 2010 and 2013. At the state level, our sample, we were lucky to be able to use the same 47 states who completed workforce information both in 2010 and 2012 for the So that group made up our state health department sample. At the local level, there was a little bit more variability in response. So we had 2,005 local health departments in this study from the 2010 profile survey and 1,953 from the 2013 NACCHO profile survey. And again, we used the occupational category designations that were shown on that enumeration slide previously. In terms of our measures, so when we looked at governance structure, we used the ASTO designations for governance structure. So we grouped together states with centralized or largely centralized governance structure, meaning that their state health departments have authority really over the funding and the decisions that are being made, even at the local level. Decentralized and largely decentralized, we group together. In those states, the local health departments have a bit more autonomy. They're more autonomous than when compared to centralized states. So they're making primarily their own funding decisions and programmatic decisions. And then we group together shared or mixed states, which are kind of a combination or a mix of centralized, decentralized structure. They have different definitions, but their sample size is so small that we did put them into one category together. As for geographic region, we use the ASTO groupings of New England, South, Mid-Atlantic, Great Lakes, Mountain and Midwest, and West, and those are groupings of HHS regions. And then we also categorized health departments into small, medium, or large, and that was based on the ASTO and NACCHO definitions that you see here on this slide, based on the size of population served. We had to use a couple different types of statistical analysis. So as I mentioned, for the state level data, we had the same health departments in both the 2010 and 2012 data, so we were able to do a direct comparison of those health departments. So the trends were analyzed through percentage change. At the local level, we didn't have that direct comparison. We had different health departments in each sample, and we didn't want to limit our sample size by restricting it to those who completed both surveys, the workforce section of both surveys. So, so we decided to analyze trends through percentage point differences between the 2010 and 2013 respondents. We adjusted data to account for missingness and potential duplicate counting of workers between state and local respondents. Okay, so for state level results, overall, we saw from 2010 to 2012, those 47 state health departments reported approximately 4% decrease in the number of full-time equivalent workers. The occupations with the biggest decreases included public information specialists, informatics folks, and behavioral health professionals. Occupations with the biggest increases included public health managers, nutritionists, and environmental health workers. When we grouped these state health departments by population size, we saw that small states reported the biggest decrease in the number of workers at 9%, medium states at 5%, and large states at 3%. We did see some occupations that reported an increase in workers, though. So, for example, in the small states, we saw an increase in nutritionists. Now, I will caution you, when you see a 92% increase, we're working with a pretty small sample size here when we're looking at nutritionists in small state health departments. We're also seeing some decreases in different occupations across these population sizes, and I apologize for the little hanging line break there after informatics. Adobe Connect did not want to work with us on that yesterday, so you'll see those throughout the presentation. I apologize for that. But I think when you look at these kind of these increases and decreases overall, what we're not seeing is a consistent pattern. There are increases in some occupations based on some state sizes, decreases in others. And we find a similar story when we group these by region. New England states reported the greatest decrease in the number of state public health workers at 13%. Followed by West at 8% decrease, South at 4%, and then Mid-Atlantic, Great Lakes, and Mountain Midwest, they were pretty stable. 1% decrease reported in the number of public health workers overall. Again, as you can see, we're varied in terms of what occupations are experiencing increases and decreases. For example, public health nurses there was a reported decrease in 3 of the 5 regions and an increase in a couple of the others. Informatics, same kind of thing. A couple of regions reported decreases in the number of informatics specialists, and one reported an increase. So when we then looked at these states grouped by governance structure, centralized states reported a decrease of 7% in terms of the number of workers overall, decentralized 4%, and mixed and shared states 3%. We're seeing somewhat of similar occupations popping up, but again, not a lot of consistency in terms of whether they're increasing or decreasing. So moving on to local level results, the number of full-time equivalent local public health workers decreased from 2010 to 2013, but we also had a decrease in the number of respondents. So that's accounting for some of that decrease there. The overall proportion of workers was relatively stable for most occupational categories. So where we saw a fair amount of profile shift at the state level, we didn't see that as much at the local level. We grouped the local health departments by population size. We saw that the proportion of public health workers, local public health workers that came from small health departments was about 13% both in 2010 and in 2013. And we didn't see any percentage point changes for any occupation. So small local health departments, pretty stable across that time period. For medium local health departments, we saw a proportional increase from 38% to 48%, a couple of percentage point changes in some of the occupations. These were the largest percentage point differences we saw, and you can see they're around 3%, 2%, and so on. And then in the large local health departments, again, pretty stable. They made up 49% of the workforce in 2010 and 48% in 2013. When we looked by region, we saw that workers in local health departments in the South made up 35% of the local public health workforce in 2010, and that decreased to 31% in 2013. We saw, again, some percentage point differences in some occupations. Mid-Atlantic Great Lakes, we had a 3% increase proportionally in number of workers. West, 4% decrease. New England was very stable at 12%. And Mountain and Midwest, we saw an increase proportionally in the number of workers. Not a lot of pattern here, other than you see administrative clerical seems to be a decrease across the board here. Well, except for in West, but in most of the regions we're seeing administrative clerical have a little bit of decrease here. And finally, by governance structure, 11% of the local public health workforce came from centralized local health departments in centralized states in 2010 and 10% in 2013, so a little bit of variation there, but not much. 2% change within shared or mixed states, and a 1% decrease in decentralized. Again, we're seeing here admin clerical seems to be the only somewhat consistent area where we're seeing a decrease, and even then it's fairly small. The biggest is 4%. So that's a lot of percentages. What does it all mean? Well, did we find variability in workforce trends in state versus local health departments? You bet. I think we did. I think we saw that the workforce profile changed more at the state level than it did at the local level over that time period. We did see changes in workforce profiles by population size, by geographic region, and by governance structure. Some notable findings in this study, we saw that some health departments reported a decrease in occupations associated with clinical services and patient care, such as public health nurses or behavioral health professionals. And you wonder if this might start to be a possible effect of changes being implemented as a result of healthcare reform. Are there changes in service delivery being made that are now we're starting to see a corresponding change in the workforce profile? We also saw that some health departments reported a decrease in occupations not specific to public health. So folks like administrative and clerical workers, informatics, information specialists. These are folks who perhaps don't have specific training in public health, and their skills and services maybe can be utilized across different types of departments. So one theory might be that it could be job loss we're seeing here, but it might also be a centralization thing that we're seeing here, where perhaps personnel are being centralized and shared across multiple departments as a cost-saving measure. Some trends also showed an increase in occupations related to program management, and this seemed appropriate to me when you think about what public health, some of the core activities of public health departments and those that are likely to remain or even be strengthened throughout healthcare reform. You're thinking of things like community health assessment and other programmatic activities that perhaps we're starting to see that health departments are increasing program managers, public health program managers. So this was a pretty short one-year study that was a secondary data analysis. So it was it brought as many questions, I think, as it answered. So some unanswered questions for future research would be, what is explaining this variability across population, size, region, and governance structure? And I think a follow-up study would really benefit from some qualitative data from health department officials, some focus groups perhaps, that can provide some context to these varying percentages that we're seeing. And again, what's accounting for this shifting of the workforce profile itself? Is it the case where some occupations are more prone to change due to budget cuts, due to retirements, due to challenges with recruitment and retention? So are we seeing that more with some occupations than others? Or is this sort of a planned change that we're seeing? Are health departments making changes to service, how they're delivering services, and accordingly making changes to the workforce profile as they move forward? I think we're not quite sure at this point. So that's my contact information for the Center of Excellence. Feel free to get a hold of us after this webinar if you have additional questions that we don't answer here, or if you have questions about any of our other research activities.
Great. Thanks so much again, Angela. Great presentation. As I said before, we have Rivka List-Levinson from the Association of State and Territorial Health Officials as our commenter on this presentation. So Rivka, would you like to make a few comments?
Can you hear me okay, Rick?
You're a little bit muted.
Hang on,
That's
let me.
Much better, much better.
Much better? Okay.
Yep.
Great. So I want to start off and first thank Angela for a really excellent presentation. As we all know, this is such an important topic for public health systems and services research. And as anyone who's kind of involved in this research knows, it's not as easy as one might think to kind of characterize the workforce and just to count public health workforce with all the different job classification systems and no national system. I think this is also a really great example of how researchers can use ASTO and HO profile data as a foundation for answering questions about the workforce and also about other things such as activities, finance, and other topics relevant to public health agencies. Angela's work that looks at the workforce by agency characteristics over time, I think it really gives us a better understanding of trends and how they have shifted over time. This also really brings up for me the idea of looking at areas of potential strengths and problem areas. So where is it that we're having a lot of success in terms of increases in public health workers, and what are areas with the decreases and how are those problematic? So I think this is something that's going to be particularly important as we have an aging public health workforce and more employees begin to retire. I think in the last ASTO profile survey, we had something like in 2016, 25% of employees are eligible for retirement. Now, granted, they may not all retire then, but I think it's going to be important to figure out what jobs those public health workers have and how the aging workforce is going to affect these. I also think that this is really, I couldn't help as I'm looking this over, and hearing the presentation, kind of thinking about Ebola, which is obviously on everyone's mind now, and, thinking about gathering this information and how this helps us understand when we face a crisis and an emergency, and do we have public health workers that are able to deal with the problem. One finding that Angela brought up that I thought was particularly interesting was that the state profiles changed more than the local profiles. I don't offhand, have an explanation for this, but I think it's going to be really interesting for future research to think about and look at this. One idea would also be to look at the previous profiles. ASTO and NACHO both have data from before 2010, and also to see with the upcoming profiles if this trend holds true or if this is a kind of a one-time thing. I also think that the findings here can be compared to or used in conjunction with a number of other data sets. So for example, right now, there's a survey out called the Public Health Workforce Interest and Needs Survey, which is looking at the major challenges that the public health workforce is going to face over the next 3 to 5 years. The survey is being administered to individual public health workers at state and local health departments. And I think that that the findings from PHWINS can corroborate the findings here and also help us understand more about the interests and needs of the workers. So in terms of future research suggested by Angela, I agree with her that it is a really important question to figure out what accounts for the variability in agency characteristics and over time. I really like the idea of using qualitative data. I think that there's a limit of how much we can learn from the quantitative data, and that using qualitative data methods will help us kind of understand more why things are happening. I also am interested in thinking more about the idea of the other category. As Angela brought up, about 30% of public health workforce currently falls into this other category, which either means that they don't fit one of the categories that we have or that the HR directors don't know where to put them. This is a really large percentage, and I know from personal experience that both ASTO and NACHO have been working hard to try and find these classifications where they do fit. But if we're going to understand the public health workforce, we really need to dive in and figure out better what these others are. Future research, I also think, really needs to focus on the implications of these changes. So not just the reasons for them, but what the effect is going to be. How are they going to affect an agency's ability to perform their duties effectively? What programs and services are going to be affected the most and how? It's also going to be important to link these changes in the workforce to health outcomes. This is really important when it comes to advocating for public health resources and for influencing policy change. In some ways, we need to have a business case for public health and be able to talk about and have data that show why, when there are reductions in the public health workforce, this causes problems. So those are some thoughts I had.
Great, Rivka. Thank you so much for the insight. We do have a few questions from some of our attendees. So Angela, Michelle has a question. What could explain the inconsistencies among states and regions? So we see a lot, obviously, regional variation. And what do you think might explain that regional variation?
Yeah, I think that's a really great question. And I see some of the other comments here on the chat box that might help with some of those theories of what might explain it. So are there categorical funding or funding formulas, or is there something happening different in some regions than others that might explain why the workforce is changing and shifting? I would say we didn't have sufficient data to root out the why in this particular study, so we're kind of limited to hypotheses. But clearly there might be something happening, you know, administratively perhaps, in different states or regions that's impacting occupational changes.
Great, thank you. And Julia Kostic had a follow-up question, which you kind of addressed. So Julia's question was particularly at the state level, the loss of specifically the information specialists and informaticists to be associated with the drop in federal emergency preparedness and response grant funding. Obviously, it's interesting to see that both the informatics folks and the information folks have had a pretty significant drop-off, and what might explain that?
Right. Yeah, I think that's a really great theory. I don't know, Rivka, do you have any thoughts on? I'm not sure what obviously there's been a funding change there, but I don't know how many of those folks were funded off emergency preparedness funds to begin with. I would imagine a fair amount.
So I don't know offhand how many were funded, but I do know that the dollars for emergency preparedness have certainly gone down. So
Sure.
I think that's really a good observation.
Mm-hmm.
And then we've got another question, kind of just about your methodology. Did you all stratify your analysis by rural and urban communities at all to kind of account
We didn't,
for
and that's
size?
Yeah, that's a good thought. We did not stratify by rural and urban. We just stratified by the size of population served.
And Jennifer Grinsdale has a question somewhat related to Dr. Julia's question. It's essentially, she said she'd be interested to see how categorical funding and funding formula has impacted the workforce. So, you know, is categorical funding a major driver of these changes? What do you think about that?
Right. Yeah, I think that's definitely an area that should be considered for future research, and I think those data are available. They weren't, we didn't link those in with our data set, so we didn't look at that question specifically, but that's a really interesting thought. If we see if we can glean any more information when we start to look at categorical funding and so on.
And looks like Sarah has made a comment noting that NACCHO added several occupational categories to the 2013, their latest profile questionnaire, which reduced the percent of uncategorized workers from 29% in 2010 to 10% in 2013. So
yeah, I'm glad she mentioned that. That just to reiterate, when we talk about that 30%, part of that is because we wanted to use the same 14 occupational categories that had been used in other enumeration studies and so on. So we were trying to be consistent with methods in other studies. But yes, so that contributed to some of that 30% in the other. We can flesh that out more at the local level because of changes made to NACCHO's profile survey.
So what you're saying is that some of the uncategorized folks that you all kind of found are actually categorized. They're just not categorized according to the rubrics you all use.
Yeah,
correct?
they fit more in an other category, meaning they weren't part of one of the 14 categories, and they're kind of grouped in with those who were actually uncategorized, who we just didn't have any information about their occupation.
Right. And Rick, this question might be more appropriate for you. Kathy Tra has written that she wants to know who's conducting the public health, the WINS survey.
That's being conducted by ASTO in conjunction with the De Beaumont Foundation. And there's basically a nationally representative sample of individual public health workers from state health agencies and a local pilot of workers from local health departments.
And just as kind of a related question, do you feel like that survey may complement kind of the larger ASTO profile workforce survey at all? How might it kind of work and complement with that?
Definitely. I think it's going to really help us kind of understand, you know, when we do the profile survey, there's, as anyone knows who's filled it out, it's huge. And so there's a limit in terms of the depth in which we can go into each individual topic. It's really just kind of, you know, trying to find out a little bit of information about everything. I think PH wins because it focuses so much on the workforce and kind of what the needs and interests are of the workforce, the challenges they're going to face. I think it's definitely going to be a big help to the profile data and kind of understanding more why we're seeing the data that we're seeing.
Right. Thank you. And then Michelle's made a comment. It would be interesting to examine workforce diversity and culture competency among the workforce, as this has been a priority for HHS. So, Angela, how do you feel about that statement?
Yeah, I think that's great. We have very limited data on that, particularly at a national level. There are some segments of the public health workforce where we can do a better job on that type of study, but overall for the national governmental public health workforce, it's more of a question of lacking a data set to allow us to do that.
Great. And it looks like Julie Kostic has another kind of comment, which is kind of boils down to, so at least one theory for the shift in discrepancies between states and local workforce, essentially the changes at the state level might be that states have hiring freezes and caps, and some folks who work for the state departments are actually placed at local departments or even in academic settings. Do you think that might explain some of those state level differences?
Yeah, it's a very interesting theory. Yeah, I'm sure hiring freezes are playing into some of this, and I think that's part of the question. Are we seeing reported job loss? Is it planned job loss due to shifting intentional shifts in the population? Is it unplanned job loss due to budget restrictions, hiring freezes, retirements that we're unable to replace? I think we just don't quite know how to interpret that yet, but I like that theory to contribute to that.
I have a question. Obviously, you mentioned the Affordable Care Act a little bit in your presentation. Could you go into a little more detail about how you think the ACA might impact the state and local public health workforce?
Yeah, well, and I think, sure, because I think this is a big area of interest, certainly in PHSSR right now. This study started with data collected in 2010, and of course that's near the beginning of sort of the rollout of ACA and thinking about how health departments might need to adapt to the changes that are described within those ACA mandates. I think it's a little too early to tell exactly whether there's a causal link here, whether ACA is actually impacting this workforce shift, but I think it's important to consider that it might have an impact. Are the services that are delivered by state and local health departments changing at all, particularly provision of clinical services or direct patient care? Are those, for example, perhaps being reduced because of ACA, and that's causing a change in what types of workers are needed? Are fewer clinical workers needed in health departments because of that change? I think it's a really interesting area, and we're in the absolute right time to be studying that and theorizing about that.
Great. I have another question. Slide 18, you've got your state level results by region. You've got it, grouped in New England, the western states, the South, Mid-Atlantic, et cetera. You've got the kind of percentage point decreases. So in New England, their workforce decreased 13%, correct? Whereas in the Mid-Atlantic states only decreased 1%. So what share of the total public health state level workforce kind of do each of those regions occupy? So is a 13% shift in New England bigger or smaller than 1% shift in the Mid-Atlantic / Great Lakes area, given they might have a different piece of the pie, if you will?
Yeah, you're right. Certainly when we're looking at percentage differences, where the different regions occupy different numbers of workers in those areas. So I'd have to pull my chart, my paper chart, to tell you exactly. But yes, you're right. The number of public health workers is not equal across those regions.
It looks like Jennifer Grinsdale had a comment that as you kind of said, the ACA may cause a shift away from direct services to a more oversight and advisory role for public health. As
Right.
opposed to
So that would be
traditional
kind of
public
consistent with seeing decreases in public health nurses and behavioral health professionals, and maybe an increase in things like public health program managers or other administrative personnel or who can provide oversight and advisement for that type of thing.
I have one more question. Kind of, this is related to your local level results. So in 2010, we had 2,005 departments report roughly 140,000 FTEs. 2013, you had just a shade under 2,000 departments report 125,000 roughly FTEs. So we saw a decrease there. Do you have any insight into how much that decrease is due to your response rate and how much is due to an actual decrease in the total workforce?
I suspect a fair amount is due to the response rate, though I don't have the information on who's missing out of that. NACCHO does adjust their results for missingness, so that may mitigate some of that discrepancy, but I suspect that some of that decrease is due to the varying response rate.
Great. Any other questions from anyone? It doesn't look like anyone else has written any comments. Well, thank you again for your presentation. It was very insightful. Do you have any last comments or anything to make?
No, I don't think so. Thanks to the Coordinating Center, and thank you to you, Rick and Rivka, and appreciate everybody's thoughtful comments and feedback. They're very useful, very helpful to try to kind of help interpret what we're seeing here.
Rivka and Angela, thank you again. All right, so that is today's presentation. Just as a reminder, the 2015 PHSSR Keeneland Conference will be April 20th to the 22nd in 2015. The call for abstracts is open. You can go to keenelandconference.org or publichealthsystems.org to learn more about it. And we also have our conference registration is open as well. Our future webinars for this year, December 3rd, we've got perspectives on primary care and public health collaboration. December 10th, integrating public health and health care lessons from one urban county. It looks like we're going to announce the dates of the 2015 PHSSR Research in Progress webinars in December. So for more information, contact Ann V. Kelly at ann.kelly@uky.edu. Thank you very much.
Thanks, everyone. Have a good